Today, we're diving into something that honestly feels like it belongs in a high-stakes Hollywood thriller, but is actually a very real, very present danger in modern healthcare. We're going to break down the exact anatomy of a hospital system downtime. Specifically, we'll be looking at an event known as a code white, and we're going to uncover exactly how these massive healthcare facilities manage to survive when their digital lifelines get completely severed. So let me just ask you this. What actually happens when a hospital's digital brain just dies? I mean, really imagine the sheer operational chaos for a second. You've got a bustling emergency room, doctors making split-second decisions, nurses dispensing critical medications, and suddenly, boom, the screens freeze. The entire network drops. The digital systems that track every single heartbeat, every allergy, and every lab result, they just vanish. The panic in that moment is completely palpable because, look, this isn't just a minor inconvenience. We are literally talking about human lives hanging in the balance when critical tech suddenly fails. So here is our roadmap for today. 1. When screens go dark. 2. More than IT issues. 3. Simulating the chaos. 4. The power of paper. And 5. The critical aftermath. Let's get right into it. Section 1. When screens go dark, the initial fallout. This is that terrifying moment the digital floor totally drops out from under the medical staff. When this happens, the facility enters what's often called a code white. Now, according to our source material, in many Malaysian healthcare settings, this specific term refers to a major system downtime event. But to be clear, we aren't just talking about the Wi-Fi being a bit sluggish in the waiting room, or an internal email server going offline. A code white means a catastrophic outage affecting the vital digital services that support daily patient care. It fundamentally threatens safe clinical decisions, because all that critical data doctors relying on, it's suddenly locked away. You see, hospitals depend on this incredibly fragile web of highly interconnected systems. A disruption might start with just one tiny technical hiccup, but man, its effects spread like wildfire. Imagine a trauma patient arriving. If the main hospital information system, the HIS, goes down, staff can't view patient records or even register new arrivals. And that triggers a massive domino effect. Pharmacy interfaces fail, meaning life-saving meds can't be ordered digitally, billing platforms crash, even PACS, the system they use for radiology imaging, just goes completely dark. A single failure rapidly paralyzes the entire facility, creating severe delays and cascading safety risks for the patients. Section 2. More than IT issues, the operational reality. We really need to shift our paradigm here, because a code white is a harsh operational reality, not just a broken server. It's super easy to treat a system downtime simulation as purely an IT exercise. And yes, you absolutely have the IT team testing servers, backups, disaster recovery, and network redundancy, which is all incredibly important. But on the other side of the equation, we have the true operational test. When systems crash, the hospital still has to admit patients, document clinical notes, and administer medications safely. A true business continuity plan, or BCP, realizes that this crisis requires doctors, nurses, registration clerks, and pharmacy staff to step up immediately. It is about keeping the hospital running and patients alive, not just rebooting a piece of hardware. So the central question a solid business continuity plan asks is this: how do essential services continue when normal systems vanish? I want you to really think about that for a second. Put yourself in their shoes. How does a nurse properly document a patient's suddenly worsening condition, or a doctor safely order a really potent drug when their primary tools literally disappear from their hands? The physical toll on the staff changes instantly. Instead of just clicking a button, nurses might suddenly have to physically sprint between floors to deliver urgent paper orders. This is exactly why a well-planned BCP has to identify which functions are absolutely critical, which ones can wait, and which must immediately switch over to alternative manual workflows. Section 3. Simulating the chaos. Controlled crisis drills. Listen, you simply cannot wait until a real disaster strikes to figure out if your backup plan actually works. Hospitals have to prepare for the inevitable through high-risk, controlled crisis drills. During a simulation, the exercise follows the exact chronological sequence of a real crisis. First up is outage detection. That's a formal notification that a critical system is unavailable. The relevant teams assess the issue, which leads straight into Step 2, code white activation. Once activated, Step 3 begins, where departments actually start performing key workflows manually. Registration staff process new patients on paper, the pharmacy receives and fulfills handwritten orders. The incident command team coordinates this massive physical effort until it is finally safe to proceed to Step 4, stand down and return to normal operations. It's a full, rigorous stress test. But what actually keeps this whole thing from devolving into total anarchy? Communication. During a downtime event, the uncertainty can honestly become more disruptive than the outage itself. The BCP must define crystal clear code white messaging. We're talking the exact activation time, what specific systems are affected, the required switch to manual processes, and, critically, how often updates will be given. Without prompt multi-channel communication, like emergency phones, internal overhead announcements, and dedicated department reps, uncertainty just breeds chaos. Staff might panic and create their own unofficial and potentially super dangerous workarounds. For example, they might start texting sensitive patient data on personal cell phones simply because the official systems are down. Controlled communication is literally the only thing that prevents that. Section 4. The power of paper, the analog arsenal. When the high-tech digital world fails, what actually catches us? It's an analog arsenal. The profound irony of a state-of-the-art modern hospital is that in its absolute darkest hour, it relies almost entirely on clipboards and paper to save lives. Every single department should maintain a physical downtime pack. This is a physical toolkit containing manual registration forms, patient identification labels, backup printing arrangements, and emergency contact lists. Think about it. Long, detailed digital policies hidden on a shared drive are completely useless if the shared drive itself is also down. These basic, highly accessible physical items become absolute lifelines for the hospital staff trying to manage urgent patient care in the middle of a crisis. And this reveals a totally wild vulnerability. You'd naturally think the biggest problem during a system failure is a fried server or compromised network, right? But a tiny operational detail, like a missing backup printer or simply running out of physical label stock, can cause massive disruption during a real code white. Furthermore, if the downtime forms in that pack haven't been reviewed regularly and they end up being outdated or missing critical patient identifier fields, that creates massive, incredibly dangerous data reconciliation problems later on. The tiny analog details absolutely matter. Section 5. The critical aftermath. The dangerous finish line. Okay, so you might think that once the IT team fixes the servers and turns all the computers back on, the crisis is over. Time to celebrate, right? Actually, scratch that. It's the exact opposite. This is one of the most dangerous phases of the entire event. As our source material explicitly states, recovery is not complete until reconciliation is finished. Restoring the system power does not immediately mean the incident is safely resolved. The hospital must protect the integrity of the clinical record at all costs. If exhausted staff just rush to back-enter all that handwritten data into the computers without a highly controlled process, they can create catastrophic errors and permanently corrupt patient records in ways that are incredibly difficult to fix later. So having a meticulous reconciliation plan is paramount. The BCP has to clearly define exactly who is responsible for back entry and verification. They must establish incredibly strict rules to prevent duplicate entries, because preventing duplication is vital. You absolutely cannot have a patient accidentally receiving a double dose of a powerful medication just because the paper records and digital records temporarily overlap. Staff have to carefully reconcile handwritten medication and lab records with the newly restored digital system and verify all the financial transactions. The paper documents then need to be properly scanned and legally retained. It's a delicate, complex, and high-stakes merger of the physical paper trail back into the hospital's newly revived digital brain. And finally, after a simulation is done, a structured debrief is mandatory. Feedback has to be collected from all participating departments to measure the exact detection and recovery times. They need to figure out what worked, where delays occurred, and, crucially, identify operational gaps. Like, for example, discovering that a department didn't actually know where their emergency paper forms were stored, or realizing that a backup phone line was totally dead. Finally, all these critical findings must be used to update the business continuity plan, because a plan that is never updated after a drill, it'll gradually become entirely useless in the face of a real emergency. We've seen today that a code white is far, far more than just an IT failure. It's the ultimate test of human organization, communication, and analog preparation in a digital world. So I want to leave you with this final thought. In our deeply interconnected society, we really take technology for granted. But when the screens inevitably go dark, whether in a hospital, a business, or your own daily life, how prepared are the digital systems you rely on to survive the chaos?